We're going to transition now to a presentation by Dr. Salisbury-Afshar, creating and implementing a low barrier model of care for people who use drugs. So I'm going to let you take it away. Thank you.
Yeah, thanks. And I'll try to be quick. And I'm just looking to see if anybody on our team. It looks like Maggie's still here. I just want to acknowledge that I'm talking about the Compass program, but this is a huge group effort. I am presenting today because most of our team members are in clinic today. So I was the one, but this is a huge team effort, and really I'm presenting on behalf of the team. So quickly, learning objectives, be able to describe the barriers that led to us opening this clinic, describe the steps taken to opening a clinic like this, and then some early lessons. So first, we're based in Madison, and there were a few things we were seeing. So one is that access to MOUD, while better here than in some places, we still find that there are a lot of primary care clinicians that aren't comfortable prescribing. We're having massive access issues. So even if you have insurance and you have a PCP, it can be really hard to get in because we have massive primary care shortages right now. We also see a lot of payer network limitations. So whether somebody has Medicaid or private pay, right? Like your assigned PCP might not be comfortable prescribing, and then your ability to switch or even which clinics you can go to is really limiting. Not everybody has health insurance, and at least locally, our federally qualified health center, which is where we would typically send people, has also been beyond capacity and not able to accept new adult patients. And many programs in the community only offer higher barrier care, meaning like multiple steps or longer waits, basically just making it harder for patients that really need immediate access to get in. The other thing we were hearing from community partners is that, especially like our syringe service programs and our outreach teams, was that many people who use substances are really afraid to access care, and especially for things like non-treatment, right? So like, I want wound care, but I don't want treatment, or I want Hep C treatment, but I don't want substance use disorder treatment or reproductive health care. And so our secondary goal, in addition to like addressing some of those MOUD needs, was really just being a safe space for people who use substances to come in and get services that can help them improve their health. So our goal, sorry, I thought somebody was talking. Our goals are to be able to offer a low barrier clinic where people can walk in and receive same day services. Our goal is to be able to provide care regardless of insurance status. And central to the model is the ability to offer medication for opioid use disorder, but we're also able to offer these other services like Hep C treatment, wound care, harm reduction education, naloxone, STI testing and treatment, family planning and contraceptive access, peer support services, transportation assistance, housing assistance, and medical case management. So really our goal is to provide as much as we possibly can for folks who are using substances in a really easy to access model. There are lots of challenges in doing this. One is that, usually clinics like this rely heavily on Medicaid payer base, which means really low reimbursement, which means we cost the system money. Walk-in models are generally not super efficient because we want to leave enough space open to be able to meet people as they walk in, but that usually means we're not hitting the same metrics in terms of numbers, which means we lose more money. We did not have an ability to provide care at no cost. So because we're not doing this under FQHC structure, it's just complicated. There's a community care process, but it requires a lot of paperwork, and a lot of our patients would have trouble navigating that. It also wasn't set up for this clinic at the time. We also see that the patients often have pretty high medical acuity and have a lot of needs, especially psychosocial needs. And so again, it's just like, this is sort of intensive, all hands on deck kind of care with really low reimbursement, meaning it just kind of becomes a bigger and bigger financial loss to the system. We also had space and staffing challenges. And then finally, like as a health system, the greatest focus is really on providing care to patients who are already in our network. And I understand that for a million reasons. I think the challenge we were seeing is that as our ERs were ramping up buprenorphine prescribing, as EMS is offering bupe prescribing or bupe administration in the field, like ERs and EMS don't have time to figure out like, oh, okay, so wait, which payer do you have and which clinic can you go to and who's your assigned PCP and can you get in within a week? Like, we just need a safety net that says like, come one, come all, right? Like if you show up, we'll see you and we'll figure it out. The challenge with all of that is that it makes it really hard to make a case to an institution because all they see is sort of like, cost, 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 cost. And so really what it took for us to be able to get started was to have this opportunity at a grant. And so I just really want to say we couldn't have done this work without a grant from the Wisconsin Department of Health Services, that it's SAMHSA money, that specifically called for low barrier medications for opioid use disorder treatment. And in our grant proposal, we said that we would offer MOUD, but we're also going to offer these other things because we think it's an important engagement tool and we know that people need them. It was a long path. And I think, in my head, because a lot of the care was stuff we were already doing in other settings, like I did not expect it would take us like a year, basically. So we had to identify space, we had to work with legal, we had to set up new cost centers. This actually was really more complicated than I anticipated, right? Because we needed a way to make sure people coming in who weren't insured or who had an insurance that wouldn't be reimburse our services, that we could bill what we call like this compass insurance, which is like basically just billing to the grant. We need to be able to do that for medical visits, for pharmacy costs, for lab costs. So that took some time. We had to build a whole new system within our EHR. We then had to staff. So we had to post, we had to hire, we had to onboard. And then the last piece is just change management. And so the space that was identified was within a much more traditional model, like a traditional behavioral health clinic model, which is very much like you do your intake and then you get scheduled a visit a few weeks later and then you come, and so really moving to this, like, just walk in, was, I think, pretty anxiety provoking from some of the staff in that existing space because it's a very different model. And so it just took a lot of time to sort of make sure we heard everyone's fears and concerns. We addressed them as we went. We sort of moved slowly enough for everybody to feel comfortable and confident. So clinic opened at the end of January. And our staffing model is that we have a behavioral health nurse care manager, a social worker, a peer support specialist, a medical assistant, and a prescriber. The goal is that we have all of these roles at the clinic every day that we're open. I should also say when we first opened, we were only open 2 days a week because that was sort of, one, we knew volume would be slow as we started, and two, this is what we sort of financially could make work. So what does it look like from a patient standpoint? So the ask is that patients walk in the morning. Why in the morning? Because in the afternoon, it's just harder to predict when people are coming. And if they come too close to the end of the day, we can't always accommodate. So we ask for walk-ins in the mornings on Tuesdays and Fridays. They literally just walk in and say they're there for Compass. Our nurse comes out and does a quick triage to make sure that we're the right place. We understand what they're looking for. We can offer that. They'll do an insurance assessment if they need to be signed up for quote unquote Compass insurance, which is really just we bill it to the grant. We'll get that put in place. And then they have an intake assessment, which is conducted by a nurse and a social worker at the same time. This is a requirement of SAMHSA and of the state that we do this GPRA intake. The reason we have 2 people do it together is that our social worker can input it into the state system and our nurse can actually type a note. This is collecting most of the information that the prescriber is going to need. So once they collect that information, and I should say this is optional, patients can decline, but to date, I think only 1 person's declined. So they input all this data, and then the medical assistant comes and meets the patient, starts to get vitals. Often we'll get a urine drug screen, maybe a pregnancy test, depending on need. And while that's happening, the physician or PA is meeting with the nurse and the social worker. And so we're kind of doing a quick huddle. They're giving us like I would say 90% of the information that we're going to need to make our visit more efficient. Our goal is really that the patient is at the center of this all the time. We want to streamline their experience. So it's not that we're doing a GPRA and then, the nurse is asking the same questions and then the physician or the PA is asking the same questions. It's really trying to streamline all of it. So we have the medical visit, we talk about medications, we order any labs, we send prescriptions to the pharmacy, which is in our building, and then I say other goodies, which I'll talk about on the next slide. And then we schedule a follow-up. As appropriate and desired by the patient, we'll also link to community resources. So we have found that having supplies like the things listed on this slide are critical. Our patients love them and honestly really need them. Having snacks, a lot of the folks we see really struggle with food insecurity. So just having some snacks that people can have is like super helpful. We are able to give out bus passes. We have some backpacks. We have naloxone. The naloxone we have in the clinic is really for uninsured folks. If folks have insurance with no copay, we'll send it to the pharmacy. We have xylazine and fentanyl test strips. We have some basic wound care supplies we can give out. We give out lock boxes. We see a lot of folks who have really unstable living environments. And so just having an ability to lock up your meds can be really helpful. We have some hand warmers and foot warmers. We have menstruation packs from public health department and safer sex supplies. So really trying to do everything we can to support folks and give them sort of physical goodies, for lack of a better word. Again, things that they really need and that can help improve their health. So we've been, so from the end of January until December 6th, so approximately 10 months with 2 days a week of clinic, we've seen over now, this is from December 6th, but 100 unique patients served. We've had over 421 total encounters. About half have had Medicaid, 26 have had private insurance. I will say sometimes the private insurance is like marketplace insurance, which means it's like covers very little. 22 patients have utilized the Compass grant, again, so meaning they were uninsured, and 7 people have had Medicare. For the sake of time, I'm not going to read this slide to you, but I just cannot say enough about like this model would not be successful without the support of many, many partners, of people referring to us, of like really helping get the word out because we are a brand new service. And so we ask every patient who comes in, how did you hear about us? And these are all the ways we've heard of so far. Services utilized, you know, again, we offer a variety of services and we're seeing like almost everyone coming in wants meds for substance use disorder, either OUD or AUD. Some wound care, some contraceptive access. We give Hep A and B vaccines. We are treating more Hep C, STI testing and treatment, all the things I talked about. And then really want to highlight the amazing work that our social worker, Lizzie, does to connect people to things like clothing vouchers, transportation assistance. We offer CCS referrals, community meetings and meetups, food pantry, sober living, housing resources. The list is longer than this, but lots of stuff. So I'm almost done. Early lessons learned. This takes time, right? Like it's a completely new service model, which in my head was going to be easy. And it was a lot harder for like a million logistical reasons, but it was also possible. Starting something like this in a big system also takes time. So I think partly as our system is big, partly it was new and different. You know, I put, if you build it, it'll take a little while before they come. And so I think, you know, the first weeks were like, oh man, everybody's going to be coming in. They're going to be so excited. And, you know, that's not how it works. It took some time, I think, to get word on the street, but also to build some trust. We've really relied and continue to rely on community partnerships. You know, starting something like this either requires that you have some kind of enhanced billing model like an FQHC, or often, you know, really relies on grant structures. Our current grant ends in September of 2025. So we are eagerly looking for new opportunities to make sure we can continue this service line in the way it is right now. We want to understand patient needs, and we will do everything we can to address them as best we can, whether it's food, clothing, housing, transportation, or other types of navigation. And then I said teamwork makes the dream work. And this is just a picture of our team, some of the members of our team. And really, like, it is such a team effort all the time. So we're, you know, I mentioned we're looking for funding. We are expanding to a 3rd day of the week, but you know, our longer term goal is really, we want to have evening hours. We want to have weekend hours. We're not there yet, but that's where we'd like to be. We want to continue to build our community partnerships. And I will just end by saying this was our holiday garb last week, or I guess Tuesday, I don't know what day it is. This has been just a huge effort. Randy is the PI on this grant, and Megan Ringo is the program manager. And then we've had this massive list, it's bigger than what I could even list here, of folks who helped us get things off the ground. So that is all I have.